Agonizing and sometimes debilitating back pain can be experienced by people with contained herniated discs, commonly referred to as a thrown-out back or pinched nerve. This injury can be accompanied by intense pain in and around the affected disc, as well as in the surrounding areas of the lower back and in the legs. Nucleoplasty disc decompression is the newest FDA-cleared method for treating contained herniated discs.
The nucleoplasty procedure is least invasive of all these procedures. Patient is placed in prone position, then we tilt the patient, place a roll blanket, get an oblique view of the spine. Of course, we drape the patient and keep everything sterile and aseptic. Use a metal marker to locate the site where the cannula will be entering the skin. The location is typically just lateral to the cell heart. You can see on the screen of the image intensifier of the articular process of the vertebral body below the disc level you intend to enter. We are going to infiltrate the skin, raise a small skin wheel, and you just need a very small amount. This is a Crawford needle, and I'm going to give it a bend here. It helps to direct the wand in the most posterior portion of the disc. Now then I'm going to take a picture just to see what our location is. And I want to direct the wand right at the spot. I want to locate the spot where I want to enter again. Now we have to redirect the needle frequently to make sure that it doesn't go too far medial. Now this time it's going more medial, so I'm going to redirect it laterally, just lateral to the superior articular process. I want to make contact with the lateral aspect of superior articular process. On this sawbone model, we can see the correct approach of entering the disc. We advance the needle to touch this surface here, right here. The bevel actually is facing medially. If we turn the bevel laterally, it will easily slip off this articular process. So if you stay close to this articular process and if you slide it slowly, you can enter the disc. Now if you're having problem and patient complains of electric shock type of sensation going down the leg, then you turn the bevel medially and you'll be away from the nerve root. Then you can advance this down, and as soon as you touch the annulus, you can feel that typical feeling of the needle tip touching something rubbery, bouncing back. If this was nerve root, patient will tell you right away. At this point, you can safely advance the needle further and enter the disc space. The needle we use for this procedure is the Crawford type of needle. This needle has a very special bevel. It's not very sharp. If you look at the bevel here, you can see the angle, the way the bevel is slanted. It's less of a slant than the regular needle. If it ever comes in contact with the nerve, there's less likely that it will penetrate the tissue of the nerve and just brush and slide off the nerve. We are looking for something which will help us prevent any kind of injury to the nerve, because as you see, when you're approaching the disc, nerve is sitting right here, and quite often you can hit the nerve. Precautions you can take to avoid hitting the nerve. One of them is that stay close to the superior articular process. As long as you hug the superior articular process, you will miss that nerve. We ask the patient to tell us if he feels any kind of sensation in his leg on the left side. And by moving this, if you don't feel any sensation, if the patient does not report any sensation, then you know you're in good shape. So now we have made the patient more from oblique position. Now he's completely prone. Now this is the AP picture, and what I'm looking at is what is the location of the tip of the needle. I may have to direct it medially, laterally, inferiorly. So we will take the two-dimensional picture. Now let's take the lateral picture of that. Idea is to enter the disc at the equator. You stay away from the end plate. Where we see that we are at the posterior edge of the disc space, actually quite a bit out. But we want to make sure that you don't want to be too far medial, because then you'll end up in the spinal canal. What I'm going to do, I'm going to direct this needle slightly inferiorly. Now here I'm touching the bone. That means I'm touching the superior articular process facet. So I have to redirect the needle laterally. And what I want to do is to direct this inferiorly so that we enter the disc space at the equator. We enter the disc space right at the center. I'll advance a little more, and I can feel it when I'm going through the disc. You can really tell when you enter through the disc. Now that's the ideal entrance for the disc, right in the center. This patient has a very good disc height for this kind of procedure. Now we're going to do the both AP and lateral. You can see that this is spinous process, and this is the medial border of the pedicle here, and this is the lamina, medial border of the lamina. We want to position the tip of the needle right at the medial border of the pedicle. in AP projection. The reason for that is that anatomically, that's where you expect the junction of the annulus and the nucleus. Because you cannot see that, so you have to go by the bony landmark. Then the next, we would do the lateral projection. So this picture shows that we are quite a bit posterior where we want to be. My aim when I'm placing the needle is to make sure that as much as I can be in the posterior portion of the disc. Okay, this is the spine wand manufactured by ArthroCare. This is the active tip, and there's a small portion which is insulation. And actually this active portion of the tip is the one which does the ablation and the coagulation. Now I'm going to take a look at that in lateral, see how far front I am. So that looks really good. Not too far in the front. I have a room to pull this needle out slightly and see if I can advance this even further. So I always want to check both AP and lateral direction. Now you can see that the tip of the needle is reaching this line here. If you draw the imaginary line joining all these pedicles, the tip of the wand actually, and I cannot advance it any further. That basically tells me that I'm touching the annulus. We are basically going through the entire portion of the disc from left side to the right side and going across through the nucleus. Now, one thing I want to make sure that I am not too far in or too far out. So I want to check the position of the needle again and make sure that I'm right at the junction. It looks like I'm right at the junction. I still have room to pull this out slightly. Okay, so we made the final adjustment. We know we are in pretty good shape. We'll do one more final check in lateral and make sure that we are not out of the annulus. You want to make sure that you're in the disc. The needle tip is just entering the disc space, just annulus. So looks like very satisfactory needle position. We'll proceed with the insertion of the wand. Now this is the depth that I reach, and I cannot go any further. You can see this depth stopper. This basically tells you the stop, don't go any further. Now if I try to push any more, I cannot. One thing I want to point out is that the wand, the needle, is in the center of the disc. In that way, you have a safety zone between the end plate and the disc space. So if there is any heat, first of all, there's very minimal heat. The temperature ranges between 40 to 70, but mostly it's 40s. If there is any chance of heat doing any damage, it's completely out of the question because you're so far away from the end plate. The spread of the heat is only a few millimeters. We are ready to insert the connecting cable to the wand. You have to align these dots, and then it will go quite easy. Now what I would do after connecting is look at the final picture, make sure the needle has not moved and the cannula and the wand, they're in the same position. So we'll take another fluoro. Looks like we are still the same at the same spot, so in pretty good shape. Now for starting, I want to show you, this is the dark marker here, and when we have wand out this far from the cannula, let's take a look where the tip is. You can see that how far out the tip is. So much of the tip is out. So even if you come this far, you're still in the safe zone because the active portion is this tip of the wand actually. And then there's insulation. So if you come this close, you may conduct electricity to this metallic cannula this far. So in that way, there's no question that you're in the annulus. This is how far deep you'll get. And the distal end of the wand is going to, of course, touch the annulus. And during coagulation, you're going to pull it out slowly. So we set the power at 2. So what I do is pull it out to the starting point just at this marker. You can gauge it from the fluoro picture that you don't want to be too far out, otherwise you'll be in touch with the cannula. So now I'll give a quick tap on the pedal and ask the patient if he feels any kind of jolt. So that's in ablation mode. And then I put my hand here holding the needle, and that's how I stabilize the needle. You can use another hand and rest anywhere you want. Speed of insertion of the wand should be such that you don't delay. If the wand stays at one particular point, it can generate heat. Then what we do is step on the pedal, and you have to be coordinated. Step on the pedal and move your hand at the same time. And then next step is pulling the wand out, and that usually typically is 10 seconds. But the rate of pulling out the wand is at 5 millimeter every second. We change it to 2 o'clock. We started with 12 o'clock, now we change to 2 o'clock, and then we repeat the process.
Nucleoplasty disc decompression reduces the volume of the spongy nucleus within the herniated disc. As a result, pressure on the weakened shell of the disc is relieved. The shell typically returns to a more natural shape, and the source of the nerve root irritation is either minimized or eliminated in most cases. Using a minimally invasive catheter and standard imaging technology that helps the doctor visualize inside the patient's disc, an accurate 1 millimeter pathway is created for the radio wave transmitter to be placed directly into the nucleus of the disc. Radio wave signals pass through the transmitter from a tabletop generator several feet away, then through the tip of the transmitter and into the spongy nucleus of the herniated disc. The radio waves produce a low-temperature ionized gas that breaks up molecular bonds in the spongy tissue, thereby dissolving volume without burning or otherwise damaging surrounding tissues or organs.
So after completion of that procedure, what I do, I push the cannula a little further in, so make sure that there's no doubt it's in. And I instill an antibiotic solution. Usually it's 2 milligrams of Ansef. I dilute that with mixture of contrast and a little bit of Marcaine. Just want to instill about quarter cc to half a cc. And then what you do is clean this and put a Band-Aid. See, the wound is very tiny. It's just a puncture wound. And you put a Band-Aid